So, good afternoon and hi from the Dead Sea in Jordan. On behalf of CRG, Dr. Fadi Farahat, and myself at Arab Medical Association Against Cancer, we are welcoming all of you. As you know, our activity is endorsed by UICC and ASCO. It's awarded by two CMEs, and it's translated to French for anyone who wants to hear it in French. Today, we are talking about the module 3 on breast cancer, more on hormone positive, HER2 negative breast cancer. First of all, I would like to apologize about our colleague, Dr. Mut'ab al-Fihedi. For personal reasons, he couldn't join us, and inshallah, soon in our next activities, he will be with us. It's my pleasure to introduce our chairpersons. Our chairpersons is Dr. Hussein Makki. Dr. Hussein Makki, as you know, he is Associate Professor of Clinical Oncology at Ahfad University for Women, Sudan, and Dr. Asia bin Salim, Head of Medical Oncology Department at Didosh, Murad, Algeria, and Dr. Basim Bahrani, well-known colleague, consultant medical oncologist at National Oncology Center in Oman. Please, Dr. Hussein, if you would like to present Dr. Fadi Farahat, and just to let you know that Dr. Fadi Farahat, after the quiz, he will pass some slides about the lecture of Dr. Mut'ab al-Fihedi in Adjuvant CDK. Dr. Hussein, the floor is yours, please.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Good evening, everybody. Here I would like to thank you, Professor Sami Khatib, President of the Arab Medical Association Against Cancer, and Professor Fadi Farahat. He is the President of the Cancer Research Group. Actually, you made our corona. These activities have enriched our knowledge and practice during. I would like to give the greetings to Professor Basim Al-Bahrani for joining together tonight for panelists and moderating this session. These activities now our first speaker, Dr. Fadi Farahat, the President of Cancer Research Group, Collaborative Group and Head of Hematology in Oncology Department, has a quiz on triple negative breast cancer. You have the stage now.
Dr. Fadi.
Doctor, you are muted.
Okay, thank you very much. You see my slides?
Yes.
Yeah, okay. I don't see Dr. Asia, Professor Asia. Excuse us.
Maybe we'll join later.
Okay, thank you very much for the introduction. Thank you for all the colleagues for being with us today. Thank you for Mr. Chairman, doctors, panelists, our colleagues, and the speaker. So we know very well that the topic today is about hormone receptor positive and HER2 negative. And I'm sorry for that, Dr. Makki. I've sent first a wrong program. So it's about HER2 negative hormone positive. And we all know that this entity is really about 60 to 70% of all breast cancer subtypes. So how familiar are we with this? And let's try a bit the knowledge. First of all, since we will be talking about, we should be talking about adjuvant, metastatic, and future. Let's start with the question about the oncotype in early stage breast cancer. Which score might indicate potential benefit from adjuvant chemotherapy? In other words, what should be the score in order to advise the patients to take the chemotherapy in adjuvant setting for hormone positive breast cancer. Please vote. And we can vote also, Vanessa. So
Vanessa, please allow speakers and chairpersons, panelists to vote.
okay, so the majority, 55%, said that it's the score 26, which is indeed right. And in the previous quiz like this one, the vote was also the same, and they voted for 58% in Europe. So the rationale behind that is that the 21 gene oncotype will be available. I mean, will push for the treatment only when we have 26 or higher. That's what we have to remember. Which of the following statement is most accurate about ER positive breast tumor? They are not susceptible to genomic evolution and respond well to treatment. They are known to undergo genomic evolution, but treatment halts growth. They are known to undergo genomic evolution during treatment, resulting in new mutation resistant to treatment, all of the above. So do they do or not genomic evolution? The first, the A, say that no genomic evolution. The second says that they do genomic evolution, but treatment still is efficacious. The C will say that there is genomic evolution, genomic progression during treatment, and this will lead to new mutation, which will lead to resistance. So please vote. Which statement is right? I can see the vote, Vanessa. Okay, and again, it's right. 53% said that there are known to undergo genomic evolution. We are talking about the breast cancer hormone positive during treatment, resulting in new mutation, which will lead to resistance to the treatment. Indeed, it's right. In the previous quiz, our peers voted 70% also. And indeed, it's well known that the ESR1 breast tumor are known to undergo genomic evolution. So yes, it's the reason why we have such progression in many cases of hormone positive breast cancer. Now it's a kind of introduction for the adjuvant for the breast cancer early setting in high risk hormone receptor positive early cancer, which a trial showed an improved survival with the addition of CDK4/6 inhibitors. I think it's an easy question. So which study is positive concerning the use of CDK4/6 inhibitors in adjuvant setting for breast cancer hormone positive? Okay. So Monarch study, it's true, and the majority voted for the Monarch study, the third option, and we voted better than what has been done previously in other quiz. And here I will take the opportunity to go through some slide of adjuvant treatment. We are sorry for the sickness of Dr. Fahd. I prepared this afternoon some slides. So as you can see, we have a number of studies that are conducted in adjuvant setting for hormone-positive breast cancer, the Penelope B, Pallas, Monarch, and Natalie trial. And studies started in different time, 2013, 15, 17, and 18 for the Penelope B, Pallas, and Monarch, Natalie. And we can see that the number of patients is different. The first, the oldest one, the Penelope, it was 1,250, but all others were almost 5,000 patients. And we will go later through the indications to see what's the difference between these trials, knowing that two trials used the palbociclib, the Penelope and Pallas. One trial, the Monarch E, used the abemaciclib, and one trial, Natalie, used the ribociclib. Remember, it was the idea was to study the efficacy of the CDK in top of the standard adjuvant endocrine therapy. So all patients received the standard adjuvant endocrine therapy, and one of the two arms received a CDK inhibitors, and the duration of the treatment was different between different trials. It was 1 year for Penelope, 2 years for Pallas and Monarch, and it's 3 years for Natalie. And we know very well that in adjuvant setting, in different indications, we have a different duration. For example, for the anti-HER2, we know that 1 year is better, it's equal to 2 years, so no need to go more, while in other trial like gastrointestinal tumor, stromal tumor, we know that 3 years is better than 1. So this will be answered later. What's the efficacy? The primary endpoint in all the trials is the IDFS. And now we'll go a bit to read about this trial. We can see that the Pallas trial, it's for high and intermediate risk. So let's talk this way. It's a stage 2 and 3, knowing that they allowed less than 20% of patients with a stage 2. The Penelope B, which is the oldest, used the CPS EG score for more than 3 or 2 after neoadjuvant therapy. Remember that these patients were allowed to receive adjuvant chemotherapy. The Monarch trial included patients considered as high risk, patients with more or equal of 4 axillary lymph node or 3 axillary lymph node plus either T3 or grade 3 or Ki-67 more than 20%. And at this time, there was a big debate about the evaluation of the Ki-67 because it differs from an institution to another. And the Natalie trial, restricted to anatomical patients, were selected based on the anatomical stage group high, which means 3, and intermediate risk stage 2. And when we look to the time since prior neoadjuvant or adjuvant therapy, the first trial or the 2 trials of palbociclib allowed the patients to be included in the trial if they received the treatment within 6 months of the initial start date of prior adjuvant or neoadjuvant therapy. So it's a limitation. And the other one, the Penelope, it was about 4 weeks, while the Monarch E, they included patients only 12 weeks, which means 3 months of the initial start date or prior adjuvant or neoadjuvant treatment. The Natalie trial allowed within 12 months of the initial start date of prior adjuvant or neoadjuvant treatment. And I don't know really if it will impact the results, the duration between the start of the between the adjuvant or neoadjuvant treatment and the beginning of the adjuvant CDK4/6 inhibitors. We don't know. We will see. Now also the treatment was different. Palbociclib was received as usually 3 weeks on, 1 week off, Abema continuously, and Ribo was started at lower dose, 400 milligram, and then after 600 milligram It's like some other medications like vinorelbine and lung CA, where we start with the lower dose, then we increase, or like the regorafenib, some recommendation allow to start with lower dose and to increase. But the background of this decision was the fact that in metastatic setting, the dose reduction to 400 milligram improved the safety while same efficacy. But I'm not sure it's a good idea, because in the metastatic setting, when patients did a toxicity, we knew that the dose was high and that 400 milligram was enough. But in the NATALEE trial, I'm afraid that this might impact the patients. But since it's only 1 month, it's acceptable. In all cases, we will also see the results. What about the duration of therapy? And we already presented that. It's very important. Should we give 2 years or 3 years? We will not know, because there is no way to compare these trials. They are totally different. The medication is different, the duration, and even the inclusion criteria. But we will see. So now we will go to the results, because we have one pending result, one pending trials results, which is the NATALEE, the ribociclib trial, which is expected in 4 years. And while the PALLAS, Penelope, and Monarch, 2 Palbo and 1 ABEMA were published. And if we go through that, I will not stop on the characteristic of the patients. Nevertheless, we can say that in the PALLAS trial, more than 80% were stage advanced 3, 2B or 3. And we have to say that in this case, we could not see any difference in the invasion disease-free survival for the both arms. So there was no difference in high risk or low risk, since we had low risk patients after a median follow-up of 23 months, and it was somehow shocking. The PALLAS trial didn't show any efficacy, so we don't need to go to the safety, since there was no efficacy. And also the Penelope trial studying the palbociclib plus adjuvant endocrine therapy versus adjuvant endocrine therapy alone showed that the invasive disease-free survival, invasive DFS, at almost 3.5 years also was not significant. The difference was not significant. We can see that the curves are really superposing, so there was no difference. So again, the second study of the palbociclib didn't meet the primary endpoint, and even when they tried to study the subgroups, there was no benefit. Some difference, but not statistical, in the Ka67, the low one, which is not really logic, and some on the overall response to neoadjuvant chemotherapy. But even in subgroups analysis, there was no significant benefit for adding the CDK4/6 inhibitor palbociclib to regular adjuvant therapy. And also no need to go through the toxicity for a result for a study which is failing. Now we go to the Monarch E, which is an important trial. And here we can see that patients again were high risk disease, and that 95% of the patients received the prior chemotherapy, which is important, and more than 85% of the patients had a stage 2B or 3 disease. So patients are at high risk and receiving chemotherapy. And fortunately for our patients, the invasive DFS, the invasive disease-free survival, was significantly different, with a significant p-value, a lot of zeros, after a follow-up of 19 months. And we can see that there was almost 30%, 28%, let's say, reduction of death when adding CDK inhibitor abemaciclib to endocrine therapy in adjuvant setting. And it was really important and interesting. And there was some discontinuation in the abemaciclib arm and the combination arm. And as you can see, it's mainly on the first months. So this really study was important to show that CDK4/6 CDK4/6 inhibitors have a role in the adjuvant setting for early breast cancer, hormone positive, HER2 negative breast cancer. We probably just need to refine the indications, the selection criteria. Now I finish with the adjuvant, and since Dr. Mut'ab Salemet Albo is not with us, we will not go through the adjuvant. Still, I would like to ask you why. The next question is, why is there discordance between liquid biopsy results from the same person run at different labs? We are asking that because we have, I'm sure it will be an excellent presentation with Dr. Mohsen Mukhtar about the future post-CDK inhibitors, and here we need the tests. So talking about liquid biopsy, why there is a different results at different lab? Is it because the samples themselves may be different? Is it because in different days blood show DNA from different groups of cells that have different mutations? Is it because the way the tests are designed and interpreted is not the same between different companies? All is wrong or all is right? Please take your time and answer the question. I've already answered because I know the answer. So is it the samples that are different? It's the timing, or is it the design of the test by itself? So 56%, all of the above. So it was not, the last two questions are not from a quiz. I personally designed these questions. I think it's very nice. So I agree, the A is right, 13%, the B is right, 10%, the C is right also, but all are right. So 56% voted for ABC, which is right, and the answer is yes, all the above. And remember, indeed, the samples themselves may be different. We are talking about mutation in the blood, so it's not the same like in the tissue. It's dynamic. It might change. Not every cancer cell has the exact same set of mutations. So yes, the samples may be different, even in the same case, if we take it in different times. The second answer, when you draw blood that has DNA from cancer cells mixed in with the plasma, different days may show DNA from different groups of cells that have different mutations. Remember, it's one of the advantages and disadvantages of ctDNA, because we know that the ctDNA is diluted in the blood, and there is a problem to try to detect the ctDNA because it's diluted with other DNAs. That's a reason. First. Second, we are talking about the tumor cells in the blood, and really it might vary from day to another, and this is a right response. And the third answer, the way the tests are designed and interpreted is not the same between different companies. There is variability in how these tests are developed, which may lead to difference in what they show. And yes, we might see a discrepancy or difference between, we are talking about liquid biopsy, not tissue, between different liquid biopsy tests. Personally, I have never tested in the same patients, for the same patients, two different liquid biopsy tests, but the data shows that there is a discrepancy if you do it. The last question, which of the following statement is most accurate about HER2 low breast cancer? The HER2 low breast cancer, as you know, it's somehow a new entity. And I hope we will design a session for the HER2 low alone. It deserves to be presented. So which statement is most accurate? Only 5% of breast cancer are classified as HER2 low HER2 expression. Okay, so low HER2, which is the IHC immunohistochemistry 1+ or immunohistochemistry 2+, but with ish negative. I'm sorry, it's missing here ish negative. So the HER2 low is the HER2 negative breast cancer when you have immunohistochemistry 1+ or immunohistochemistry 2+ with ish negative. So is it only 5%? Is it true that trastuzumab may benefit women without IHC 3+, which means with low HER2? And is there any new antibody drug conjugate that may be effective in the treatment of the tumors with low HER2 expression and all the above? So again, HER2 low is only 5%. Trastuzumab is efficacious in HER2 low. New medications are here, antibody drug conjugate, helping this entity. Please vote. So the majority, no, it's equal. 43% are with the new data suggest that a new antibody drug conjugate may be effective, and 43 say that all the above are right. So for the first questions, the HER2 low is almost 50% of breast cancer classified as HER2 negative. It's a big number. So which means that if we have 60% what we call luminal, which hormone positive, HER2 negative, it means that we have indeed 30% HER2 low. Again, I recall that just to remind you that it's immunohistochemistry 1+ or immunohistochemistry 2++, but in situ hybridization negative. So it's 50% and not 5%. The trastuzumab is not beneficial for patients with IHC 3+. And we also remember the gastric cancer, the trastuzumab was also positive and highly efficacious in IHC 3+, while it was not the case in IHC 2+, and even in IHC 2+ ish negative or IHC 1+. So the trastuzumab is designed only for the highly expressing HER2 tumors. And finally, the third question, there is new data suggesting that the antibody drug conjugate may be effective in targeting such type of HER2 expressive tumor, and specifically the trastuzumab deruxtecan. We know very well that this drug is efficacious in second and third line after failure of the classical anti-HER2, but apparently in a phase 1b study, it shows this molecule shows a great beneficial in patients receiving already more than five cancer, majority more than 5 cancer regimen. The duration of response was almost 10 and a half months, 10 months and a half, which is important in the post 4 or 5 lines. The PFS was 11 months and the overall survival was 20 months. So, and in the independent committee review, the response rate was 37%. So it's a new entity. I just wanted to include it here because it's nowadays considered as a part of the hormone positive HER2 negative. Remember, the HER2 low breast cancer is the HER2 showing 1 positive IHC or 2 positive IHC with negative ISH. And with that, I finish my quiz presentation and I give the floor for the dear panelists. Thank you very much.
Thank you very much for the interesting talk. I think now I give the stage now for my colleague, Dr. Basim Al-Bahrani, to introduce the next speaker. Welcome, Dr. Basim.
شكرا جزيلا دكتور. أفتح البرنامج. our next speaker إن شاء الله راح يكون دكتور جوزيف قطان. Professor Joseph Qattan, he's the president of the CME office, Faculty of Medicine at St. Joseph University, Beirut, Lebanon, Beirut. He's going to talk to us about advances in HER2 in hormone-positive breast cancer, more on CDK4/6 inhibitors. Prof, all floor for you.
Thank you, Dr. Basim Al-Bahraini, for your kind introduction. And here I am sharing my slides. Are you seeing my slides?
Yes, we see it.
Yes.
And I want to prepare an arrow or pointer. Okay. So first of all, I wish to Dr. Mut'ab Al-Fuhaidi, our friend, to get better soon. And I would like to thank Dr. Sami Al-Khatib, Dr. Fadi Farhat for this kind invitation. So my talk will be on CDK4/6 inhibitors and the management of metastatic hormone receptor positive HER2 negative. And we know there was a lot of presentation, a lot of talk about this issue. So I choose a different way. I'm moving my slides. They are not, well, so these are my disclosure. And I choose to devise the presentation in two parts. The first one will be a summary and overview of all the DK4/6 studies inhibitors associated with hormone therapy in first line and second line, with a focus in PFS and overall survival. Then few slides about from the ESMO highlight, the ESMO 2022, where I will present the 3 more studies. And I start with the overview of the CDK4/6. So it's clear that the advantage that created by target therapy when it's associated to hormonal therapy was very tremendous in the literature. Almost since 10 years, we have a lot of targeted drug like everolimus, like PA3K, like CDK4/6, and the role of these molecules are to overcome resistance to hormone therapy. Here we have a schema with the receptors of the estrogen, and we have different molecules that intervene in the deepness of the response, in the amplification of the response, and in the circumvent of resistance, like the CDK4/6 inhibitors. We have already 3, the palbociclib, ribociclib, and abemaciclib. Already in the literature, we have more than around 8 studies, well done, phase 3, with almost more than 600 patients per study. And we divided the study in 3 major groups. We will focus in the first group, where the patients or the studies are used in the first line, and the companion drug is the aromatase inhibitor. And here we have the Monarch 3, the Paloma 2, the Mona Lisa 2. In these studies, Abema with aromatase inhibitor, Palbo with aromatase, and Ribo with aromatase. Also, we have a part of the patient of Mona Lisa 3, while Mona Lisa 3 used fulvestrant. And we have the Mona Lisa 7, which was completely dedicated to premenopausal women. Let's have a quick view on the progression-free survival. The primary objective of these all studies With the Paloma 2, there was a randomization of Palbo, 125 milligram per day plus letrozole versus placebo plus letrozole. And the difference was significant in favor of the combination, with a median PFS 27.6 versus 14.5. Let's move to the Mona Lisa 2. We have almost the same design. Ribociclib 600 milligram, that means 3 pills per day, with letrozole compared to placebo plus letrozole. And the primary endpoint PFS was in favor of ribociclib and letrozole, 25.3 months versus 16 months. And the third study was the Monarch 3, also same design, patient, Abema plus non-steroidal aromatase inhibitors versus placebo plus non-steroidal aromatase inhibitor. And the primary endpoint, the PFS, was also in favor of the combination Abema plus endocrine therapy, 28.2 months versus 14.7. In the same time, there was a study called Mona Lisa 7 dedicated to premenopausal women. Also, the PFS was positive in favor of the combination ribociclib plus goserelin plus non-steroidal aromatase inhibitor versus the placebo plus anti-LHRH and the aromatase inhibitor. And the difference was 23.8 months for the ribociclib arm versus 13 months for the placebo arm. Now, if we want to look to all these studies, the Paloma 2 with palbociclib, the Mona Lisa 2 with ribociclib, Monarch 3 with abemaciclib, and Mona Lisa 7 with ribociclib, and the part of Mona Lisa 3 where patients were in first line, but this time was fulvestrant. And we look to the efficacy, the hazard ratio concerning the progression-free survival. We have almost the same benefit, the same magnitude of benefit, 0.56 for Mona Lisa 2, 0.56 for, Mona Lisa 2, for Monarch 3, 0.54, for Mona Lisa 7, 0.55. Now let's move to the second part of the study, the phase 3 studies dedicated to second line. And we have here Monarch 2 and Paloma 3, and always the major part of Mona Lisa 3. And the drug with the CDK4/6 was fulvestrant. And here also we will have a quick overview on the PFS of these 3 studies. The first one, Monarch 2. In Monarch 2 also, there was more than 600 patients, almost 700 patients, Abema plus fulvestrant versus placebo plus fulvestrant, and the difference was significant in PFS in favor of abemaciclib, 16.4 versus 9.3. The second study, Paloma 3, almost the same design, palbo plus fulvestrant versus fulvestrant plus placebo, and the median PFS was 11.2 months versus 4.3 months. The third study also, it was the ribociclib plus fulvestrant versus placebo plus fulvestrant, but the patients of Mona Lisa 3, like I said, were divided into first line and in second line. So even in both line, first and second line, there was a significant difference in progression-free survival, although the numbers were higher because there were patients from first line included, but here we have the results, a significant difference, 20.5 months for the fulvestrant plus ribociclib versus 12.8 for fulvestrant alone. And if we want to see these 3 studies combined, we have here in this table Paloma 3 and Monarch 2 and Mona Lisa 3, and we have here the hazard ratio of the PFS almost the same, 0.5 for palbo, 0.53 for abema, and 0.57 for ribociclib. Now let's move to the overall survival. There were, as a second endpoint, the overall survival in these studies, and there were a positive overall survival in some of these studies. The first one, Mona Lisa 7, it was the first overall study published showing a significant difference in favor of ribociclib plus gozerine and non-steroidal aromatase inhibitor. The difference was significant, and the median overall survival with ribociclib was 58.7 versus 48.0 months in the placebo group. The second study, Monarch 2, abema plus fulvestrant versus placebo plus fulvestrant. Also, the difference was significant, 46.7 months versus 37.3 months, and the p-value was 0.0137. The third study, the Mona Lisa 3. In Mona Lisa 3, with a long follow-up, 56.3 months, we have also a significant difference between the arm with ribociclib versus the arm of placebo, 53.7 months as median overall survival versus 41.5 months for the placebo arm. And here in 2019, in the ESMO, there was a separation between patients who received the in Mona Lisa 3 who received the combination in first line versus patient who received in second line, and the overall survival for each group was significant in favor of ribociclib. Here we have the result of the first line, not reached for ribociclib versus 45 months for placebo, and for the second line, it was also significant, 40 months versus 32 months in the placebo arm. While the Mona Lisa 2, we have also with a longer follow-up, also a significant difference in overall survival, 63.9 months median overall survival with ribociclib versus 51.4 months for the placebo arm. So if we want to gather all these studies, we have here with the green tick, the studies with significant difference in overall survival in favor of the CDK4/6. Here we have the Mona Lisa 2 with a significant gain in overall survival in first line. Mona Lisa 3, first and second line with fulvestrant. Also, we have a significant difference in overall survival. And in Mona Lisa 7, in premenopausal woman with aromatase inhibitor and grisolene, also we have a significant difference in overall survival. Also in Monarch 2, we have with the abemaciclib plus fulvestrant, a significant difference in overall survival. While in Monarch 3 is still pending, in Paloma 2 pending, but in Paloma 3, we have a negative result. We don't have a difference in overall survival. So let's move now to the second part. Are you hearing me? Are you following me? Dr.
Yes.
Samuel Khatib, the voice.
Yes, we are following.
Yes, Professor,
Yes.
go ahead.
We are following.
I have few slides concerning the ESMO highlights. These are highlights in metastatic breast cancer in patients who were included in Mona Lisa 3 and are in first line. We have now an updated overall survival. We already see this slide showing the overall survival in 2090 in favor of ribociclib. Now I will show you the updated overall survival. It was presented by Patrick Niven at the ESMO. Here, the design of the Mona Lisa 3. Here are the 365 patients considered as first line included in the study and received ribociclib plus fulvestrant versus placebo plus fulvestrant. And here we have the updated overall survival, almost at a median follow-up of 70.8 months. We have the significant or the maintain of gain in overall survival, 56.5% at 5 years versus 42, and a median of 67.6 months with ribociclib versus 51.8 with placebo. So this is the first highlight. Also in the same study, in the same group of first line Mona Lisa 3 who received ribociclib plus fulvestrant, we have a significant difference in PFS2. Also, we have a significant difference in chemotherapy-free survival, 49 months versus 29 months. Now I move to the second study. It's a very small study presented as poster in the ESMO. It's an answer for our daily practice for patients who received prior CDK4/6. Can we re-challenge with CDK4/6? So the answer, even if the effective of patients are very low, we have an impressive positive result. Among 8 patients only, there was five patients who had objective response or even clinical benefit by giving abemaciclib after failure of a previous CDK4/6. Very small study, but interesting. The third one, it's a sub-analysis of the levels of ER, PR, and HER2, RB2 in patients who receive palbociclib in a study called the PADA-1 trial. The PADA-1 trial is a big French study, and the objective of the study, or the design of the study, is to assess the emergence of ESR1 mutation by blood biopsy, like presented by Fadi Farhat already. They are testing the ESR1 mutation occurrence at the inclusion at 1 month and at 2 months after the start of palbo plus aromatase inhibitor. And once they detect the ESR1 mutation, they modify the study and they replace the aromatase inhibitor by fulvestrant. So it's a dynamic study based on the mutation occurrence during treatment. Very interesting study, and they assess the value, the level of each of these variants. So for the estrogen receptor, if we have a high level, 80%, we have a better overall survival than less than 50%, even among the positive. The same for progesterone receptor, better PFS when we have more than 80% positivity versus less than 50% positivity. The same when they studied the HER2 by immunohistochemistry or other variant, and I jump immediately to the conclusion. In the multivariate analysis, they found that age, absence of visceral metastasis or bone-only metastasis, de novo advanced breast cancer, percentage of progesterone receptor, and HER2 1+, 2+ status are independent factor that reduce the risk of progression and or death among patients receiving first-line palbo and aromatase inhibitor. And the PR, progesterone receptors, very interesting status, is the strongest prognostic factor and remains an independent factor in multivariate analysis. With this, I finish my presentation. Thank you.
Thank you, Dr. Joseph. If the panelists allow me to keep the questions till the end of the session,
Yes, okay, doctor.
Okay, no problem.
Okay, so Dr. Asia, how are you,
Yes.
Dr. Asia?
Yes, I am here.
How is Constantina?
Fine. Too hot.
Too hot?
Yes.
Good. So please, would you like to present our third speaker, Dr. Mohsen Mukhtar?
Okay. It's my friend. Dr. Mohsen Mukhtar is professor of clinical oncology at Cairo University. Dr. Mohsen Mukhtar, are you here?
Yes, I'm here.
How are you?
I'm good. Thank you.
Fine, fine. So go ahead with your presentation.
I'll start sharing my screen.
Mechanism of CD4 forces. Yeah.
Thank you very, very much, Asia. Really longing to see you
Me too.
coming to Constantina, even though it's hot. I'd like to thank Dr. Fadi as well as Dr. Samati for inviting me to be part of this group today. Very, very interesting talks by Dr. Fadi and Dr. Joseph Khattan, who led the way on what we're going to do next for these patients. So, mechanism of CDK4/6 inhibitors and their resistance at juvenile breast cancer. We just saw the data that came out from Dr. Joseph on the addition of CDK4/6 inhibitors, and we have 3. Exactly the same PFS, hazard ratios are exactly the same, but in the end, we just got overall survival benefit of around 24% or 20+%, depending on which trial you're looking at. 4 of these trials showed an overall survival benefit, but some trials didn't show an overall survival benefit. And which patient do you have in front of you? And that's really going to be interesting. As we've seen, unfortunately, at some point, these patients will progress. Some will progress quicker than others, and the key is to know which of your patients is going to progress quicker than the rest, so that you have a planned analysis of what you're going to do for your patient. Another key portion is to try and test your patient in terms of genomics before you start off your CDK4 inhibitors, maybe because if you want to use fulvestrant in the coming lines, then you might not use it in the first line, especially when we're talking about postmenopausal patients who have received some sort of AI. Testing for ESR is going to be really important, because we've seen this from Joseph, but I just want to elaborate a bit more on this. Because what we know is that if you block your estrogen receptor, or if you degrade your estrogen receptor by giving an AI or tamoxifen or the downregulator like fulvestrant, what you're going to see is that the other portions of the cell cycle are going to pick up, namely that PI3-AKT-mTOR pathway. This, when it happens, is going to cause some phosphorylation of the retinoblastoma gene, and then you're going to be pushing your cell cycle outside of that CDK4/6 inhibitor pathway and going through another pathway like the PI3, or if you've got low HER2, like Fadi was saying, that might add on into how the cell cycle moves for your patient with hormone receptor positive breast cancer. So what do we have for these patients, and what should we be testing? Well, we have alpelisib for the PI3 kinase mutated patients. We have everolimus, which has no biomarker testing till today. We have the PARP inhibitors for patients who are BRCA1 or BRCA2 mutated. And we have the oral selective estrogen receptor downregulator, or SERDs, with no biomarker testing. And then we have the antibody drug conjugate for the against HER2 for the HER2 low patients, as Fadi was saying, and I'll elaborate on that in the last couple of slides. Now, if we look at what I'm going to be testing for my patient. Now, if you do a full genomic profiling for your patient, what you're going to see is that some genes are picking up. One of these genes are like the retinoblastoma gene 1. This picks up after giving hormonal therapy or CDK4/6s, and it will denote a resistance to CDK4/6. Your ESR1, or what's known as the estrogen receptor mutation, this occurs more in the metastatic phase, and especially if your patient has received some sort of hormonal therapy, and this will denote a resistance to the AI, not a resistance to the CDK4/6. So like Fadi was saying, and like Joseph was saying, there is an ongoing trial. If you pick up that ESR mutation, continue with your CDK4/6 and shift from an AI into a selective estrogen receptor downregulator like fulvestrant. Then you have others that are constant there, like your fibroblastic growth factor receptor, your PI3 kinase. This is actually consistent whether it's in the primary or in the metastatic setting, and that's why you can test your PI3 kinase mutation on archived tissue from the patient in the breast, because this actually occurs very early on. You can see that the difference between the metastatic setting and post AIs is only around 1%. The other is that P53 mutation that we all know stands out with any type of cancer. So if we look at PI3 kinase inhibitor, and this is why I'm saying you probably will need to test your patient out early on in the setting of the metastatic setting for the PI3 kinase, because whatever you give a patient with a PI3 kinase mutation, you can see that they have worse prognosis, whether it's on hormonal therapy, whether it's on chemotherapy, whether you're adding a CDK4/6 or not. What we can see is that the mutated patients, the ones here on your left and in the red here, 49-51% in terms of death or response, as compared to the wild type where you get 69% response. And the overall survival with whatever you're giving, and in this case it was chemotherapy, the overall survival was, as you can see, 23 without the mutation, while it was only 19 months with the mutation. And if we're talking about CDK4/6s in specific, this was tested out in the Paloma 3 trial. Patients with a PIK3 mutation, the response to CDK4/6. Now you look at the hazard ratios, they're exactly the same whether the patient is mutant or wild. So don't get me wrong, if you have a patient that is PI3 kinase mutated, still they will benefit from your CDK4/6. But if you look carefully, the curves are lower on the mutated side than compared to the wild side. So you expect that your patients will have a poorer outcome to the CDK4/6 inhibitor, and you probably will need to change it even faster as you go down the line. The PI3 kinase AKT-mTOR pathway, this is in approximately around 40% of the patients with hormone receptor positive. So it's quite a bunch of patients that will need or do have this mutation. It obviously promotes estrogen receptor growth, irrespective of the estrogen receptor on the cells itself, and maybe the addition of a PI3 kinase inhibitor should help. And this is what was tested out in the SOLAR-1 trial. This was alpelisib plus fulvestrant versus a placebo plus fulvestrant after prior AI. What we can see is that the progression-free survival jumped from 6 months to doubling to around 11 months, hazard ratio 0.65. And in this trial, unfortunately, only 6% of the patients had prior CDK4/6 exposure. The overall survival from this trial, as you can see, was increased by around 8 months for the alpelisib fulvestrant. And as you can see, again, in patients with liver or lung mets, so visceral mets, again, denoting that we might not need chemotherapy for these patients. And as I've shown you, patients with PI3 kinase mutation will not benefit as well from chemotherapy. But here in this trial, liver, lung mets, 37 months overall survival as compared to 22 months on the placebo, hazard ratio of 0.68 and a hazard ratio of 0.86 in terms of an overall survival benefit. The other trial that came out on this on the PIK3 mutation is the BioLeap trial. This was again alpelisib fulvestrant after a CDK4/6 inhibitor, which is probably the first line, as we've just heard from Professor Joseph Kaptan. What you're seeing is a progression-free survival of around 7.3 months. So this again sort of mimics that in what was seen in the SOLAR-1 trial, giving us more confidence that this drug probably works for our patients with the PI3 kinase mutation. The primary endpoint, as you can see, 46% were alive without progressive disease at 6 months. Progression-free survival was 5.6, with a response rate of around 63% in these patients. And what we can see is in these patients, none of them did achieve a CR, but you had good partial response, you had good stable disease for your patient. So around 63% in terms of control or clinical benefit for your patient. Now, one of the things to note is that whenever we're using a new drug is you need to know the side effects of the drug. One of the things to monitor vigorously when you're using alpelisib is the blood sugar and hyperglycemia. Patients who are pre-diabetic and diabetic, you should closely monitor, and you should intensify your anti-hyperglycemic treatment, counsel on the lifestyle and the dietary, because this is one of the things that needs to be monitored. You need to check for the fasting blood glucose for your patient prior to addition, and the glycosylated hemoglobin, so that you'll make sure that if your patient has or is pre-diabetic prior to giving this therapy, we can see that it is reported in around 65% of the patients. However, more than grade 3, it's only in 37%. Look out for it if your patient has a high fasting blood glucose, more than 100, low high-density lipoprotein cholesterol and or high triglyceride. Body mass index, again, if your patient has a body mass index more than 25, then again look for that hyperglycemia and always monitor it more carefully in this subset of patients. The second drug or target that we can target is the mTOR inhibitor. The mTOR inhibitor is sort of down the line from that PI3 kinase mTOR pathway. So you're really going down to the core center of this. But again, with mTOR inhibitors, we don't have a specific target or a test for these patients, and that's why we can't predict whether the patient is really going to benefit or not from your mTOR inhibitor. We've been using it post CDK4/6 for our patients. It does work, but again, if you have a PI3 kinase mutation and your patient is eligible or can afford the PI3 inhibitor, then PI3 kinase inhibitor would be probably better. The Bolero trial, this was with everolimus exemestane versus exemestane for these patients. Remember, this trial was published around 10 years ago. This was in patients refractory to letrozole or anastrozole. These patients had not received a CDK4/6 inhibitor. And what you can see is that there is a clear benefit for the use of everolimus in this group of patients. But again, stressing that none of these patients in these trials had received a CDK4/6 inhibitor. You're getting a progression hazard ratio of around 0.4, so 60% benefit. And if used in first line, it actually works even better. But again, CDK4/6s, because of the decreased toxicity, because of the increased tolerability, and probably the efficacy, because now we do have an overall survival benefit from the trials, with a CDK4/6, then I would still recommend that CDK4/6 come in as first line. The Bravo study is there. It's a post-marketing study. What we can see is that they were testing because we had the problem of stomatitis with patients on mTOR inhibitor. And what we can see from the Bravo trial, probably this is the best thing that came out of this trial, is that whether you use it in first line or second line, you're probably getting the same progression-free survival. And that's why, again, if my patient can get a CDK4/6, then I'd go for the CDK4/6 in first line. If she's PI3 kinase mutated, then I'd go for the PI3 kinase inhibitor. If not, then I would use my mTOR inhibitor. Again, as I said, the second line is as equivalent with an mTOR inhibitor as is in first line in terms of progression-free survival, even though only a small subset in the Bravo trial had received some sort of CDK4/6 inhibitor. More interestingly are the PARP inhibitors. We know that PARP inhibitors have come to play a role, especially in patients who have some sort of BRCA mutation or HRD in terms of ovarian cancer, but BRCA mutation over a wide spread of disease, including breast cancer. And this was tested in germline BRCA mutated patients in two trials, the Olympiad and the IMBRCA. Both of them tested the PARP inhibitor in the patients who had received prior chemotherapy. In the Olympiad, it was less than or equal to 2 lines of chemotherapy. In the IMBRCA trial, it was less than or equal to 3 lines of chemotherapy. And now when we're talking about patients with hormone receptor positive but BRCA mutated, then maybe you've given them a CDK4/6 plus hormonal therapy. Probably down the line, if they're BRCA mutated, this can be used. But remember, when your patient is BRCA mutated, you are going to get a benefit in progression-free survival that is with a hazard ratio of around 0.5 something, so around 45 to 50% benefit for these patients in terms of progression-free survival for these patients. But if you look more carefully to the patients who are receptor positive and BRCA, you can see that the hazard ratio here in comparison to the triple negative is only 0.82 and 0.43. So if I get a patient that is BRCA mutated with hormone receptor positivity, again, it wouldn't be my reach to give the PARP inhibitor, especially if I'm giving it in first line, because of this subset analysis from the Olympiad trial, telling us that the hazard ratio is not that impressive, only around 18% benefit in terms of progression-free survival. And obviously, when you're looking at PARP inhibitors, your patient is most probably going to come in with a fatigue. Look for the anemia prior to determining that this fatigue is just from the drug. You need to look for the anemia that is associated. Neutropenia, thrombocytopenia is there. And you need to withhold the drug till the anemia, your hemoglobin goes back to 9, as well as absolute neutrophilic count being more than 1,500 and the platelets being more than 75 before you continue your PARP inhibitor. Now, the new interesting drugs are the oral SERDs. So these are fulvestrant-like drugs that are actually oral. We all know that fulvestrant comes in the form of injections, which are actually quite bothersome for a couple of patients that have had that will be complaining about having that injection monthly, first 2 weeks and then monthly after that. So the oral SERDs have come in, and one of the oral SERDs, or a lot of these were presented in the last San Antonio. Elcastrand, this was versus standard of care in hormone receptor HER2 negative patients. These patients had CDK4/6 inhibitors. They had 1 line of chemotherapy, and they were randomized to Elcastrand versus fulvestrant, anastrozole, letrozole, or exemestane as single agents, and they were tested out for the ESR mutation. Now, whether your patient has an ESR mutation or not, elcastrand was actually better in terms of progression-free survival, hazard ratio 0.69. And if the patient had an ESR mutation, it was 0.56, both statistically significant. So if I'm going to use these drugs, again, then I do not need to test for that ESR if I'm going down the line. But if we look at the progression-free survival, it's actually around 3 months. So really not that eager as yet. Maybe when they come earlier down the line, maybe they will show more benefit for our patients. The AMIRA-1 trial update, this was the second SERD amicastrand plus palbociclib. What we can see is that there is a response of around 32%, clinical benefit rate of 73%, and the median progression-free survival of 14 months. So again, this is something to look at. Maybe if your patient has received fulvestrant as a single agent for bone mets only, then the addition of this as an oral agent plus palbociclib could be an option for your patient. The Emberer with the last of these SERDs, so the last oral immunostrand, this overall response rate, what we can see was around 6%, clinical benefit of around 48%. 37% of these patients had ESR mutation. But what you can see is that a lot of them had received multiple lines of therapy. And that's why the response from this, and this was in both breast and endometrial cancer. So really nothing to talk home about. But what I think the one that is coming and may have some updates in the next ASCO is the elcastrand. This may prove, in addition to a CDK4/6, better than something like fulvestrant plus the CDK4/6, as there are ongoing trials with this. These are the future directions of this. They're going to be combined with CDK4/6 with mTOR inhibitors, and are going to be used in earlier lines rather than down the line from this. The last target that we're going to be talking about today is that antibody drug conjugate in the HER2 low patients. And this is the DESTINY-4 trial. This was trastuzumab deruxtecan given in HER2 low breast cancer. This was the DESTINY-4 trial. We have an update from this that it is a positive trial. These were immunohistochemistry 1+ or 2+ with ISH or CISH or FISH negative tumors. This was versus physician's choice of any chemotherapy. We have a press release that this is a positive trial. If you are really looking forward to the data from this, this is going to be presented in the next ASCO on June the 5th, actually. And I think it's around 2 p.m. Chicago local time. Now, as Professor Fadi was saying, the HER2 low, where am I going to be looking at these in the HER2 low? What we can see is that in all patients, and this is data coming out from the Austrian study group, in all patients, HER2 low is in around 35% of the patients. If the patient is triple negative, the HER2 low is in around 22% of the patients. And if the patient is hormone receptor positive, it's in around 40% of your patients who are considered as hormone receptor positive will be redefined after this DESTINY trial with being HER2 low, and this drug can come in as addition. Remember, this is not a miracle drug. It does work. We're going to see the data on the DESTINY-4, but what we know from deruxtecan is that you have some interstitial pneumonitis, and obviously the high cost of this drug will make it maybe not affordable to anyone. So this is the paradigm that we're used to, the use of CDK4/6, add on alpelisib to that, add on mTOR inhibitor to that. We're now going to add in what's known as the PARP inhibitor. We are also going to add on the oral SERDs. And if your patient is hormone receptor positive and HER2 low, maybe you will be adding on the antibody drug anti-HER2 conjugate. So these are what's new beyond the CDK4/6 for your patient. Again, I would urge you to test for PI3 kinase, test for germline BRCA mutation from very early on so that you can plan what you're going to do for your patient. HER2 low will be known priorly before you even start treatment because the patient will come in with her HER2 results. But I think PI3 kinase mutation as well as BRCA mutation is something that you need to test for your patient so that you have a good diagram of what you're going to do with the patient, because in the end, all our patients with metastatic breast cancer will progress at some point, and having something for them is really beneficial. And thank you very much for your attention. And I will stop sharing my screen.
So thank you, Dr. Mohsen, for the excellent lecture. Now the panel discussion, please. If you would like to discuss the lectures and to answer the questions that we have in the box.
Prof. Mohsen, what's your age limit for CDK4/6?
My age limit for CDK4/6, I'll tell you that I'm right now using one of the CDK4/6s in a patient that is 72. So I tend to look at the patient in terms of the performance status, but obviously patients who are older and friable, I would try to keep off the CDK4/6s, especially if they've had prior treatment. But I don't think it's really an age limit. I have gone beyond the 70 age right now with good response and good tolerability.
So beyond 80 and 90s?
No. I don't treat beyond 80 and 90. I think hormonal therapy as a single agent is quite perfect for these patients. And I don't even bother them with fulvestrant. I use AIs.
Any questions from the panelists or from the group?
There is many questions in the chat box, please. Can you take?
Okay, in the era of, can I take some of these questions, Fadi? I'll go through some of these questions.
Yes.
So in your opinion, 65-year-old lady with breast cancer, T2N1, hormone receptor positive, HER2 negative, received neoadjuvant chemo with stable disease, modified radical mastectomy. She has hormone receptor positive, HER2 negative, 26/27.
So you are not seeing the question? Hello?
I don't know if it's the net is bad.
I will read the question. Do you recommend TDX for low HER2 in metastatic or adjuvant? So I consider that the question is for both of us, Dr. Mohsen and myself. Do you want to answer, Dr. Mohsen? Do you recommend to use the TDX in adjuvant or metastatic setting? Okay, Dr. Mohsen is not here. For metastatic setting, it was approved in more than first line, second or third, and in adjuvant there is no data at all concerning that. So your opinion for a 65 True, Dr. Joseph, are you hearing us?
Yes,
Okay.
yes, Fadi, I agree. There's no data concerning the drug in adjuvant settings. True.
Okay. Have you read also the case of the 65-year-old lady with the breast cancer, CT2N1M0, HER positive, HER2 negative, received neoadjuvant chemotherapy, you don't know which chemo, stable disease, then MRM, axillary lymph node dissection. So the patient didn't respond. It's still T2N3, HER2 negative. Yes, we usually see such case. So I presume that it's the same patients. Then after PET-CT, multiple liver mets, score, biopsy of liver lesion, triple negative metastatic breast cancer. What do you recommend? Now we have the keynote trials using pembrolizumab with chemotherapy, nab-paclitaxel or others. We can recommend it. If pembrolizumab is not affordable, so there is no data which one to use. Some will say that you have to use the platinum salt or taxanes, and the adriamycin is also an option. It depends what did you use in neoadjuvant. We don't know what have you used in neoadjuvant. Do you agree, Dr. Basim, on that?
Yes, yes, I agree with you, Dr. Fadi.
Okay.
But it's course, the primary is ER/PR positive, metastatic triple negative. So we'll treat it as a triple negative.
Yes, we take
and behaving like a triple negative patients.
Exactly. So in the era of unavailability of PIK3CA mutation test, can we shift from aromatase inhibitor plus palbo to fulvestrant plus palbo in case of endocrine resistance? It's, I think Dr. Kattan would like to answer that. So in the era, if we don't have the alpelisib, we don't have we cannot test the PIK3CA mutation, can we keep the palbociclib and shift from aromatase inhibitors to fulvestrant? I presume that assuming that ESR1 is the reason of resistance.
If we want to follow the algorithm, usually when we don't have the PI3K or BRCA1, BRCA2 mutation, look, it's the place of giving exemestane plus everolimus. It's more defined in this situation. Instead of keeping the CDK4/6, already we don't have any data concerning the beyond the resistance to CDK4/6 if we can give the CDK4/6, unless we will give abemaciclib. We have all data concerning the fulvestrant alone, but even before the era of CDK4/6, I think it's more suitable to give everolimus and exemestane in this situation, and keep fulvestrant or the new SERD once they are available to fourth line.
Dr. Ben Asia, okay. Thank you, Dr. Kattan. Can we have your opinion, Dr. Asia, if you are with us? Dr. Makki.
Yes, I think that in this era and in the clinical situations in this country, I think in the region here, we can go for the Kisgali single agent as when the hormone resistant after aromatase inhibitors have been resistant. So that's for both. You have sometimes you don't have the test in the country and the financial problems at the same time.
Okay, yes, we can say that the presentation done by Dr. Mohsen was the algorithm was clear, and it's true. If you don't do the PIK3CA mutation, the everolimus is one of the best options till now, plus exemestane. And there was, we said previously that it's toxic, but nowadays we see that it's not really toxic. And there is new papers talking about the mTOR inhibitors experience. So you can look at it. It's a very nice drug. And I totally agree, Dr. Kattan. If you use exemestane everolimus, you can keep fulvestrant to the third line. It's an option. Totally agree. Can TDM1 be used in low HER2 breast cancer?
No.
Yes.
No. No.
Low HER2
No.
breast
No.
cancer. TDM1.
TDM1, no.
No, I saw the
No.
anti-drug conjugate. Yes.
No.
TDM1.
No. TDM1 is not.
Do we have data, Dr. Mohsen?
We had a phase 2 trial on that, and it didn't work actually. Okay.
So, by the way, for the low HER2, I'm sorry, I missed between the anti-drug conjugate and the other. So, the only drug that were tried, there is another drug other than the dextrican trastuzumab. There's another. Yeah, there's some other drugs.
There is another one with that are coming up in maybe next ASCO, yani, in a couple of days. Maybe we need to do, like you said, one on low HER2 after ASCO.
Okay. Any other questions? So I was searching in what I read recently. So there is, as we said, trastuzumab deruxtecan. There is also a drug, trastuzumab duocarmazine, T-duo. We'll hear about it. It's also new. So there is a lot of work on that. There's also nelipepimut. I don't know what is it. It's a phase 2 trial in the HER2 low. So yes, we might discuss it later on. Any other questions from the audience?
Yes, I think we have some questions in the chat from Asma. Can TDM1 be used in low HER2 breast cancer?
It was answered, Doctor.
It was answered. Okay.
No, the answer is no. Hussam Zawam is asking, is there an explanation for HER2 low being HIC positive while it is ISH negative? It's probably because of the count that they do with the FISH, depending on the number of hits that you get on the ISH reading. So there is a cutoff point for it being positive.
Okay, I think we can stop here if there is no more question.
There's one more question. PI3 kinase mutation can be done on old biopsy. Yes, you can do the PI3 kinase on your old biopsy so long as it is archived and better for less than 2 years.
Okay, so let's close. I would like to thank really all panelists and speakers for the excellent lectures and discussion with almost 100 participants from MENA region. I would like to thank them all. Just to announce that our next activity will be next Tuesday, June 7th, about lung cancer. And the floor is yours, Dr. Fadi.
Thank you very much for all the attendees, for the audience, for the speakers, panelists, and for our chairman. Also thank for Science Pro. And I would like to emphasize on the fact that even though our activities are sponsored, but as you can see, we talk about it without bringing the brand names on the presentation. So we would like to keep our talk as it is, purely scientific, as it was today. Our activity today is sponsored by Novartis, who agreed totally to run the activity purely scientific. So thank you very much, Novartis, and see you next week, all of you. Thank you and bye-bye.
Thank you very much.
Good night.
Thank you.
Bye-bye.
Bye-bye.
See you next Tuesday, inshallah.
Inshallah. Thank you very much.
Yalla, you are welcome all. Excellent.
Good night, everybody.
Excellent team.
شكرا دكتور سامي. شكرا جزيلا.
يا أهلا يا أهلا.
شكرا للجميع. تحياتي. الله يبارك.